Okay, now we're going to start the CPRs, but you have a PDF. Make sure you printed out your PDF, and what you're going to be looking at as the candidate is just these things that have the blank pages that don't have the answers on it. So the first sheet is the candidate sheet. The second sheet is the patient sheet in each one of these cases. So this one says Bonnie is a 35-year-old homemaker and a part-time painter, so you're going to do a case history on her because you know nothing. That's what you're going to be asked to perform. Then raise this up, Dr. Laura, just real quickly. The second station is going to be after you wait 90 seconds in the hall. You're going to go in. There will be a binder where there's vitals, there's a pain drawing, there's some labs, and there will be something in the view box. Now, I just drew the x-rays and kind of gave you some love hints if there's something goofy about them. But then after that, raise it up some more. Your job is to pick 3 answers from each one of these, and then we'll talk about the whole case after you have completed all that. So let's review one more time. You get how long to do a prep for your... Can we draw this down? How long do you get to do your prep, your roadmap for this case history? 5 minutes, or I'm sorry, 90 seconds. Then you enter the room. How long do you get in that room? 5 minutes. Then you leave that room. How long do you get in the hall to prepare for this station and look at the notes that you've collected? 90 seconds. Then how long do you get in this room? 5 minutes. Got it? All right. And we'll see you on the other side of Station 1. Now, as you review this case, we're going to go through it step by step. Did you talk to your patient? Did you use full sentences? Did you interrupt them? Did you introduce things like we're going into past history, which would maybe allow them to say, well, no, that's not remarkable. There's nothing in there, doctor. Or did you just say, have you had it before? Did you have any surgeries? Because it might be some value to say, okay, we're moving into family or occupational or social history, because that gives them an option to just, nix the whole subject area. So that's one test skill I want you to look at. Now, she's middle-aged. Okay, she is a homemaker. They've only given you the name Bonnie. If they'd said Bonnie, Scazzarelli, then you would say Miss Scazzarelli. They just said Bonnie, you say Bonnie, but you have to follow the format that they give you. She has some hip pain. It's the left side. She was gardening and shoveling. Okay, so we know she was doing some kind of activity that was, physical. It's been there a month, so it's not going to be a fracture. It's not going to be a dislocation. She's shoveling, walking, climbing ladder makes it worse, okay? And ice sometimes helps. That's interesting. Ice a month into this is helping. It's dull, it's achy, it's from her hip to her lateral knee. Oh boy, howdy, that sounds like TFL problems. Okay, and that would alter the biomechanics and swell up bursts and those kinds of things. So those are kind of plausible answers, but it doesn't mean they're right. I mean, she could have cancer in her hip. We've got to keep moving. The pain is constant. That's kind of an eerie sort of finding, isn't it? She has been painting. What does that say? She has not been painting as much. Okay, so I guess, she was trying to, do some part-time work painting, and it's affecting it. She's not sleeping well on her left side, so there's tenderness when she sleeps on it, and she needs to stop walking after 3 minutes. So there is a significant amount of pain. We walk into the next room. Okay, and Dr. Laura, you might have to move this around as they look at it, but it looks like there's really, couldn't see the greater trochanters. We're not really seeing anything on the lateral side of their hip, so there's probably not much to gain there. But boy, her vitals are normal, and we get trigger points and pain here. So they've told you right there that there's trigger points. And that's in the glute med area, kind of gluteus medius, kind of AB doctors, even TFL problem, but I would say more glute med, and the labs are normal. So let's go down here and look at answers. If I go with the iliotibial band, do I have other answers I can pick with it? Let's take a look at this. I like the glute med trigger points. I like that. The iliotibial band would go to the knee, so that kind of, I'm liking that. The AS makes no sense. Trochanteric fracture, we said, can't be going on. Iliopectineal bursitis would be in the front. That makes no sense either. Ischiogluteal bursitis, it's your hinder binder. That could make some sense. Okay, make it localized, snapping, clicking, hurt every time that you walk, but piriformis fan, no. Sacroiliitis, not SI, she's not pointing back here. Paget's ridiculous. Trochanteric bursitis, that's even better than that one, because that would happen later. This trochanteric bursitis with tensor fascia lata, that would be immediate response. So I think I like 10. I like 4, and I just love 3 because they gave me the glute med trigger points right there. So I think we're going to stick with 3, 4, and 10. Is that how you did it? Then I have to come down here, and it doesn't say case management, it says initial case management. What would I do first? So even if there's 6 things here that I would do, what 3 would I do first? When I stick that word initial in, that kind of tweaks that question a little bit. So a trial of adjustment sounds pretty good. Knee x-ray, so-so, ultrasound, calcium supplements. She's 35. I don't think we have to go there yet. Passive stretch of the hip. I like that one. So far I like trial chiropractor and stretch these hip. Cryotherapy, didn't she say ice helped? And when you do trigger point therapy, what is something that we do? We ice it. That says right here. Trigger point therapy is usually kind of, we beat you up and then we ice it and try to squeeze all that crap out of there. And so that's what I think it becomes a really good idea. Serum studies, we don't need anything. Probably everything would be normal anyway. Thoracolumbar cryotherapy makes no sense for the case that we're on, and breathing instructions. See, those would all go with the AS answers that you should not have picked. And SI joint cryotherapy, we did not pick the SI joints. So it's looking an awful lot like we're going to like 6, we're going to like number 5, and we're going to like number 1. So 1, 5, and 6 then become our answers. Okay, now we're on our second case history, but realize we're at station, where is it? Station 3 already. So station 1 was the case history performance, station 2 was the case history answer the questions, right, the post-encounter probe. So you've already done 2 stations of your 25 on your test. Now we move into station 3, you're standing outside the door, a 55-year-old male appliance salesman. Boy, that didn't tell you anything, but it will say performing case history. So you would even have to enter a room like this and say, hello sir, may I have your name? Okay, and start with that. Well, what brought you in today? Now, mostly on boards, they tell you this is Mr. Brown or Michael Moore or somebody like that. So they'll actually give you a name and then use their surname if that's done. But I just wanted to talk about, if no name is given, then you request it, okay? All right, so give yourself 90 seconds to prepare your roadmap. Then 5 minutes to enter this room. Let your patient see the answers. Good luck. All right, we're dealing with a headache this time. Once we went in and talked to we'll call him Mr. Moore for right now. We talked to him. He tells us that he's having a headache. Now, ding, 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 ding. I want you to get particularly nosy about timing. And timing can wrap into onset and timing. Like it was 3 weeks ago. Well, you ever had this before? Has it been constant for all those 3 weeks? And, is it kind of worse and better as it happens? What kind of waxing and waning occurred? So episodes, those kinds of things. So get really nosy about timing. So it's his right frontal region. He was struck by an open cupboard. It was 3 weeks ago. Nothing's making it better. It's going from supine to standing makes it worse. It's deep. It's achy. None. 5. Constant getting worse. Nothing like this ever before. Now let's go back up there and check that age again. This is that time when them subdural hemorrhages happen. This will slow leak. So it can be a quick hemorrhage, or it can just kind of be a drip, 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 or a hematoma that gets set up in there and just causes pain and doesn't resorb. So that's a real plausible possibility here, or that this man has had a stroke or something. But usually trauma and stroke aren't connected. Trauma, subdural are connected. So then we've got Coumadin. So he's been on Coumadin. He's on a blood thinner. That already tells us that he's more prone to have a leak. Raised by his great aunt. He never met his parents. No problems at work. Does not smoke. Drinks a pack of cigarettes. 9 2/5. So he's a little bit of a drinker. Alcohol every weekend. Dizzy, confused, disoriented. So there might be some central nervous system damage if we're kind of paying attention to this. But there's no tinnitus, no eye or urinary problems. So what we have is kind of some neurological deficit taking place with a slow drip or leak. That's what it's sounding like. Okay? At least if we look at the worst case scenario headache as we come out of here. But we should have come out of here with neural and vascular systems that we are concerned about. We move into the next room and we get vitals are normal. So his vitals aren't changing much. His SED rate is normal. So boy, and we look at the lateral A to P and lateral cervicals and they're normal. So we get like nothing. So your collection of information is all you have to go on, because you basically knew that. So realize then your data is what matters the most. How well did you collect? So talk to your patient if you're not doing your due justice here. So let's take a look at what you selected for a minute, and then we'll talk about what I think are the right answers. All right, now, right along I've been saying that I really think it's a subdural hematoma because he's just the right age for it. He's on Coumadin. There's just all kinds of setup for it. There's been a little bit of trauma. So I like that one right off the bat. So I'm going to pick it out. And that would be an intracranial headache. So I picked the AKA based on the system where it is, and I've already got 2 good answers and I'm feeling good, and I'm just kind of looking around and perusing the other answers going, well, he doesn't have a fever, so I can get rid of temporal arteritis or meningitis or encephalitis or any kind of headaches like that. The timing of it, it kind of takes out some of them, that it's been there, what was it, 3 months?
3 weeks.
3 weeks?
Yeah.
Okay. So the 3-week headache, so we kind of look at that. And if we're going to get normal x-rays, then multiple myeloma and cancers and malignancies, those kind of things that might show up as destruction of bone are going to be gone. And Meniere's, he wasn't dizzy. We can kind of cross that one off. That it isn't piercing and coming and going. What was the timing of this headache? Can you tell me one more time? Look, Dr. Laura, for me.
Okay.
It was?
Constant.
Constant. Okay.
Progressively worse. Nothing.
Progressively worse, constant. So cluster, it's only an hour long. It comes and goes. Tension headaches are worse in the afternoon. So timing is your friend, and you end up with subdural hematoma, intracranial headache, and you feel good about it. So now all you got to do is come up with what is the other answer I could pick, and take a look. He hit his head on the cupboard if you go back and read about this. So really, I told you, subdural is more linked to trauma than a stroke is. So there's your post-traumatic headache. So we end up with 2, 3, and 8. Now, what does it say again? Oh, initial again. They're throwing that one at us. Okay, so even if there's 5 right things to do, what are the top 3? Well, this is really important that we do at least a CT of his brain. So we're going to, this says spine. They have made that wrong. That is ugly. Okay, but that's wrong. Okay, so is there a CT of the brain? It is not here. Oh, how creepy of them. All right, well, Davis series is for trauma, but he hit his head. This is not the appropriate time to do. Davis series is for neck trauma. We've got a skull problem. So these two are very tricky. These would be very good if it was a cervical trauma case, a whiplash, but wrong here. So brain MRI, okay, we can do that. We can justify it. It's jacking up the bill a little bit. It's the best answer we've got so far. Ketone evaluation, of course, we're not worried about fat metabolism. Cranial nerve exam, that's potentially appropriate. Sinus radiographs, not so important in this case. His SID rate, if we looked up, it was normal, so we're not going to repeat that. Sinus transillumination, these would be more for the sinusitis case. B12, we don't need to. Hey, ophthalmoscopic exam. We could look for the papilledema, the enlargement. Okay, so I like ophthalmoscopic exam. I thought cranial nerves was acceptable. He's got some, central nervous system damage and the MRI. So I think out of this mess, I like 3, 5, and 10. But I will tell you that the best answer up here is a CT of the skull. So just remember that. CT of the skull is appropriate, but they did not give it as an answer. So sometimes we have to pick the best answers that are available. Okay, this is your final case history, number 3. This time we have a first and a last name, and this is very typical for boards. So Sally Slavic is a 38-year-old female retail worker. Enter and perform a focused case history. Now, even if they say the word focused case history, do a complete, do your review of systems, do everything. So how long now do you have in the hall to make your roadmap? 90 seconds. How long inside the room to collect your information from Ms. Slovak? 5 minutes. Remember the warning, 30 seconds remaining. I'll see you on the other side. Alright, now, the best place for them to get you an emergency or an ER thing will be during the case histories, because in the ortho-neuro rooms you'd want to stop performing, do vitals, and send them out. So this one's going to be a hot abdomen. So let's see how you're going to handle this. You've got the abdominal pain, you've got the right lower abdomen, she's telling you, so you should now be ruling in and out certain viscera, certain things that live down there. So we've got, we've got the female anatomy, we've got the colon, we've got the appendix, we've got, a few players that kind of stand out to us. It started the night before, so this is very rapid onset. So whatever we're picking, it's rapid. Nothing's making it better, it's deep, dull, sharp, last night. It's intense, radiates to her low back and below her belt. Okay, so we've got just a generalized area then of pain. It's not radiating like anything neurological. It's definitely staying visceral. We've got 9 constant pelvic inflammatory disease a year ago. That's a ding, ding, ding. That's why that past history is just usually full of, You know, if they've ever heard it before, if they're seeing a doctor, if they're on medications like we got the Coumadin on the last patient, you know, there's just usually some gold mines in here. And in the cancer patients, we often find a big ding, 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 ding in the family history that somebody's had cancer and died of it. So remember this past and family. They're very important things. She's got 4 children. She's stands a lot at work. The social was unremarkable. So again, if you said going to social unremarkable, you didn't have to go through all that. But look at review systems. Her menstrual period
It was 7 weeks ago.
7 weeks ago.
And she's not on birth
she's
control.
Not on yeah, look at all this.
She's spotting. Uh-oh.
So we got female trouble. Ding, ding, ding. And so let's move this up. Let's take a look. She's got a temperature, so she's on fire. This is a hot belly. It's showing us that her belly hurts. It's saying 12,000 for white blood cell count. Okay, they didn't give us the red blood cell count, or if they, you know, that would be nice if they'd given it to us. If they had, I'm going to bet you dollars to donuts it was low, so that you could pick things like maybe an ectopic pregnancy that's ruptured or a ruptured ovarian cyst. And again, you have to pick appendicitis because what they've asked for is not the diagnosis. They've asked for diff dies, which means you're going to pick what you think it is plus the things close. Then we said when we started off, who lives down here, who's in that quadrant. So the more likely thing is that she has a female problem going wrong. So pyelonephritis is out, Crohn's is out, ulcerative colitis is out. We keep the female issues in, the ruptured ovarian cyst and the ectopic pregnancy. Take a look at who we have over here. Ankylosing spondylitis, ridiculous. We got a normal A to P pelvic. Look, it was an old one, 98. They're just telling you to dismiss it. Diverticulitis, cystitis, all bad answers. So the only answer that can be a diff die for this case, which is probably a wrong answer, is appendicitis. Now to make appendicitis right, a couple of things could have been changed. But one thing that should have been different is that should have been more like 15, 16, maybe even up into our shilling shift, 17 and 18,000. So the white blood cell count really mattered. The red blood cell count would have really helped us confirm if one of these things has ruptured. So again, initial case management. They seem to be hot on that for this test. So what are we going to do for the, oh, by the way, let's review what we had up there. So that was 1, 7, and 9. Now down here for initial case management, CPK is for what kinds of things? That's for dead heart muscle, dead skeletal muscle, dead portions of the brain. So that's not useful here. Pregnancy test. She said it's 7 weeks. Been 7 weeks. That's a good answer. Platelet count probably metza. CBC with a differential. We already got our white cell count. We don't really need that. Abdominal ultrasound. That's sounding intriguing. That's interesting. Sounds appropriate. Refer to emergency room. I'm feeling good about right now, okay? Because we don't want to. Oncologist, she doesn't have that. Cancer. KUB film. It's some minor help. Refer to rheumatologist. Absolutely ridiculous. And pyelogram would mean you thought her kidneys were a problem. So I like refer to the emergency room a lot. I like the pregnancy test. We need to rule that out. And I think the belly ultrasound makes the most sense, makes a lot better sense than the KUB film. We'll get a lot more visceral information there. So I really like 2, 5, and 6 with a couple of so-so answers after that.